It is now my pleasure to introduce Dr. Allison Bryant Mantha, who is an associate professor of obstetrics and gynecology and reproductive sciences at Harvard Medical School and senior medical director for health equity at the Mass General Brigham. Thank you.
Thank you so much, Dr. Simon. I really am grateful for the opportunity to present on reflections on what we take away from the COVID-19 pandemic and its implications for maternal health inequities. So I really am honored to present on such an esteemed panel that's been assembled today and tomorrow. I have no financial disclosures, but what I'll bring to you today was sort of perspectives from our own department, from our greater institution and our health system, and then what I've learned from our state perinatal quality collaborative efforts, as well as my time briefly serving on the Massachusetts COVID Maternal Equity Coalition, as well as lastly, my role in the ACOG COVID working group that's really tried to keep up with the guidance, but always through the lens of health equity. So next slide. I think that this, needs no introduction for this group. This is obviously sort of the core of the issue that we're talking about today over the course of these 2 days, is just these drastic inequities in terms of maternal mortality. Next slide. And then in many other sort of unrelated maternal morbidity outcomes, both in disparities in health outcomes as well as inequities in healthcare services. Next slide. I think what we all sort of also recognize is that from Hurricane Katrina to Hurricane Harvey to Deepwater Horizon oil spill into Hurricane Maria, we've all borne witness over time to the effects of natural and unnatural disasters on communities of color. I like the quote from the former New York City Commissioner of Health, Mary Bassett, who sort of said that epidemics, and I think by extension then disasters and pandemics, uncover the fissures in our society. Next slide. So it came as a surprise then to really exactly nobody on this call that we saw these inequities in COVID-19 infection rates and death rates from COVID and from hospitalizations. Next slide. I'm sort of a model person, and so I think that this feels like a nice mathematical or sort of model terms of sort of putting voice to what we're talking about, which is just there's an interaction, there's an effect modification between the severity and the quality of given exposure, in this case a hazardous event, and the sensitivities of those affected. And so that then has effects on short and long-term outcomes. Next slide. Sometimes when I talk to folks about health inequities and how we got here, which is probably not that relevant for this group, but next slide. What I try to say is really, how could we not have gotten here? So if we go to the next slide, we have gotten exactly the system that we designed, sort of following the legacy of chattel slavery, of Jim Crow, and of all the lingering structural racism that our system actually leverages to serve to elevate some groups over others. Next slide. When we think about those contributors to health and healthcare inequities, I sometimes sort of borrow from this rubric from the American Journal of Public Health that points to maybe patient level factors that I don't actually buy into that much, but certainly provider level factors that meet at the level of the clinical encounter, all of which is encased in how we sort of deliver healthcare and how that system is broken in terms of perpetuating inequities. Next slide. But what really has been missing from this is the structural factors. And if you advance, I think, 2 more, really, if we think about poverty and wealth, stability of housing, food security, and really structural and interpersonal racism, these would dwarf all of these others in terms of their contributors to health and healthcare inequities. Next slide. I think during the COVID-19 pandemic, we've talked a lot about social determinants of health, and I do think that these are important because the integrity of each of these is so interwoven with a community's ability to respond to a crisis. Next slide. I think as Dr. Career-Perry said earlier, we really cannot talk about social determinants of health without understanding the underlying contributors to social determinants of health, which really are structural racism. So from things like underlying policies like redlining or neighborhood other segregation, the detrimental effects, for example, or differential effects of the GI Bill after World War II, all of these led to differential social determinants of health, which then, next slide, led to things like hypertension, diabetes, and obesity differentially in populations, and those have had direct correlates on COVID-19 incidence and outcome. Next slide. So if we think about the statement of the problems in COVID-19, particularly in the early days, the inequity and the burden and the consequences of the disease were differentially applied by population, as we've heard. So in some ways, sort of the living circumstances and working circumstances of many of our patients made social distancing and in-home isolation very challenging. Particularly for us, many public health messages were not delivered in multiple languages. So we live in a community that's multilingual here in the Boston area, and many of those early messages were sort of delivered only in English. In the early days, access to testing, which now seems so ubiquitous, was not uniform by population. And the prevention mechanisms, so namely home confinement, increased the risk for things like gender-based violence and other mistreatment, particularly for folks who may have had fewer resources to accommodate these. We certainly know that the racist and xenophobic attitudes were a threat to the patients as well as to the healthcare workforce. And then, as we've just mentioned, comorbid conditions that were risk factors for severe COVID-19 illness were differentially distributed in the United States, already sort of in a way that was sort of with a backdrop of maternal mortality and severe maternal morbidity that was differentially applied. Next slide. This is just an example. I'm sure that all of you at your institutions had ways that you were sort of dealing with the COVID-19 pandemic in terms of health equity. We kept sort of a running list of particular topics that we felt that we could get a handle on within our healthcare system. So things like, how are we running our practice? How is bias and mistreatment showing up in the everyday care of these patients? What was our data and reporting systems? What was our research infrastructure? And how can we make sure that that was best serving the communities who had the greatest need? What were our philanthropic efforts, and could we direct those towards the pandemic? Thinking about community health, and then also issues of reproductive justice, which we felt were near and dear to us in our Department of OBGYN in particular. Next slide. As we moved forward to sort of thinking about reopening and recovery, what we really wanted to do was to continue our efforts to sort of limit the spread of COVID-19 in our particular hotspots and focus on social needs, to think about gradual reopening of the healthcare system and making sure that that was done in an equitable fashion, and then really applying the lessons that we'd learned from the COVID-19 pandemic to healthcare in future state. Next slide. So I will present today just a few best practices, and I'm not sure that we really can call them best practices from our institution and around the region. Ultimately, if we have time for Q&A, would love to hear what other folks have done in their areas. And this is by no means a census of all best practices, but really a sampling of what was done in our area and what we learned, and what really we can take all of us take from this to our next stages in our work. Next slide. So in terms of thinking about data, I think it's really clear to sort of say that we have no quality without equity. Thank you so much. So as we continue to think about the COVID-19 pandemic, we really wanted to continue to track differential rates of COVID disease, of our healthcare utilization and safety metrics by patient demographics, so by race, ethnicity, language, socioeconomic status, and community factors. I think that as Dr. Scott mentioned earlier, these metrics are clinical and really are just the floor of what we should be collecting. And we should also be exploring patient experience in the pandemic. We really look forward to her contributions and others in this space. Next slide. We also just need to really take a population health approach. So I think that for many of us practicing in clinical care, the patients that are on the list in front of you to be seen are your patients to be seen that day. And if one of them doesn't show up, perhaps they're marked as a no-show, and you can go and sort of reach out to those folks. I think we learned in the COVID-19 pandemic is that we really need to take a population health approach to understand who is in our catchment area, who we should be seeing, because clearly there's lots of opportunities for loss to follow up amongst vulnerable populations, and particularly those that are affected by the COVID-19 pandemic. Next slide. We also wanted to make sure that we were not using our data inappropriately. So really recognizing that aggregate and epidemiologic data can help to guide our policy efforts and maybe guide sort of community resource allocation, but they really should not ever be used at the individual level. So it parallels our efforts right now to eliminate racialized medicine, and using race ethnicity at the individual level to guide clinical care, which generally has no place in the medical system. And what we'd find is that we would sort of have folks from our Chelsea community, for example, who would show up to labor and delivery once we instituted a universal screening. So that's a population that was hard hit by the pandemic. And when folks from that area might screen as negative, somehow people would sort of say, you know, wow, it's surprising. Maybe this is a false negative. And really, we needed to have ways to really document these instances of racism, microaggression, and biases, and really to think about how we could aggregate these and take them forward to make sure that we were not using these in a discriminatory fashion going forward. Next slide. We really highlighted, obviously, the importance of communication. And so here in this space, particularly for folks who had language preferences that are other than English, really understanding and highlighting those preferences for our patients, as well as for our staff. So we have a multicultural, multilingual staff in whom English may not be their primary language. And to the extent that we were trying to send public health messaging about hand washing or not showing up to work if you were sick, or here's how you could access testing, that needed to be done in translated languages that were tailored to patient and staff preferences. We also created a lot of multilingual care extenders. So we had a Spanish language care group that really was able to stand up care that was delivered in patients' primary language without using interpreter services during the sort of most pressing time during the pandemic. Next slide. Obviously, we needed to sort of focus up care. So it is true that social determinants are truly underscored or are differentially applied because of structural racism and policies that came before. But in the time of the pandemic, we certainly need to understand people's access to and to understand that that may be differential across the pandemic. So the person that we screened at the beginning of the pandemic who was not food insecure, for sure by the third trimester might have been. And so that led us to do some frequent screening for things like food insecurity and housing instability. We also thought really about how we could expand our healthcare team. And this should have been obvious from the very beginning, but embedding behavioral health specialists and community health navigators really went a long way during this pandemic. Next slide, please. I think also what we really learned is that, we needed to focus on the positive and to focus on community resilience. I really like this quote that sort of says, one potentially daring but promising strategy is to elevate community resilience, an essential public health service, and to integrate community resilience measures as performance benchmarks. And so while we have not gone to this extra step yet of understanding community resilience measures, we really did rely on communities to know their own selves and what was best for them, and really integrating sort of community feedback as we move forward in this pandemic. Next slide. What did we not do particularly well? I would say that we didn't really meet the metric of having patient-centered maternity care. Next slide. I'm super grateful for the work of the Massachusetts COVID Maternal Equity Coalition, the steering committee of which I was able to serve on for a short time. And this was a group that really did elevate the voices of birthing people who gave birth during the pandemic, and continues to do so. These were two town halls that were occurred about a year apart, so one in June 2020 and one just now in June 2021, to understand sort of the challenges and how we were failing, honestly, birthing people during the pandemic. Next slide. And this paper, I think, authored by many that you've heard already from before, sort of giants in our field, I think was really one that I clung to very early on. So just this notion that we'd say over and over that we disrupt the myth that policies that uphold the human rights of birthing people and policies that decrease the risk of COVID-19 transmission are mutually exclusive. I think we can't say that enough. We sort of rang the safety bell probably too often in means of sort of discounting patient experience and the human rights of birthing people. Next slide. We can't really talk about COVID equity without talking a bit about COVID vaccine equity, inequity, and so what we need to reach this goal. Next slide. So this was a depiction from the New York Times, I think probably back in March of this year, that certainly does depict by both state as well as by race ethnicity that there are differentials in terms of access to and uptake of vaccine by population. Next slide. This was as of May 2021. What you can see is that there's disparities or inequities in the percentage of populations having received at least one COVID vaccine across the United States. Next slide. And this is out of proportion to the burden of disease. So if you look at that last line for the District of Columbia, this is something from the Kaiser Family Foundation looking at Black patients in particular, or Black communities in particular. So whereas there's Black community members make up 46% of the DC population, they received 40% of the 40% of the population was vaccinated, and yet that is below the percent of cases. So Black patients were overrepresented in cases as well as in deaths, so 70% of deaths. Next slide. And so these were some of the early headlines around sort of vaccine hesitancy, which we've all talked a lot about. So that Black people are justifiably wary of a vaccine and their trust must be earned. Experts warn of low vaccine trust amongst Black Americans. And this became very quickly, I think, the narrative around differential application of COVID vaccination amongst populations. Next slide. And some of this in the early days was not totally unreasonable. So we knew from Kaiser Family Foundation that Black participants in surveys were more likely to say that they would not get it or probably not get it. But again, looking at this is August and September of last year before a vaccine became available. Next slide. And so really there was a lot of focus on this sort of group of populations that would say that they would only get it if it required or definitely not get it. Next slide. But I think what we did not pay as much attention to is really this larger group that sort of says they're just going to wait and see how it's working, right? So this is what the definition of hesitancy is. This doesn't mean that it's a shutdown, never going to do it, but there's a reasonable, it's not unreasonable for populations who have been historically marginalized to say that they're going to wait and see how things go. So next slide. And so really, I think that the language needs to turn, and it really has turned, I think, in many sort of state jurisdictions to thinking about how we improve vaccine access, because I think that that really is the underlying concern at this point. And so these are several strategies that various states have sort of taken up in terms of thinking about how they can prioritize vaccinations in communities that need it the most. Massachusetts has taken on a number of these. And so I think that this really needs to be where our focus is going forward. So with that, I will end just with this slide. That was probably my best day in the pandemic, which is the day that we stood up a clinic or participated in a clinic at the Reggie Lewis Center in Boston. I will end it with there, and happy to take questions towards the end. Thank you so much.